So it's a very good question, right? I think the first thing that one should talk about is sort of the statistics. These tumors are rare. If you look at the incidence in the United States, you're talking about 1 to 2 people per 100,000. So it's not a very common cancer. It's not like breast or lung. In the United States, there are about 25,000 people every year diagnosed with this type of a tumor. And so it is rare. It's gaining attention because people like Ted Kennedy are afflicted with it. So anytime you have a prominent person, either in the government or in the arts, a cancer that is not very prevalent starts becoming not popular, but at least more prominent in the public eye. So brain tumors are rare, but they've sort of come to the attention of the public over the last recent years because we've had quite a few people who've been prominent and who've been afflicted with it. Because they're rare, they're hard to study. And what makes them also difficult to study is the fact that there are many different varieties of brain cancer. So while we focused on a single organ, which is their brain, the pathology that it involves is very diverse. The tumors that we really focus on are the ones that are most malignant or the ones from which people die. So the kind of tumor that, let's say, Ted Kennedy had, which is called glioblastoma multiforme, is the deadliest variety of brain cancer. And, you know, the 2-year survival is less than 25%. So it gives us a lot of opportunity to study this, to run clinical trials, to do research in order to try to advance the disease and offer patients hope for something that has been historically difficult to treat. So the most common form of brain cancer is actually metastatic brain cancer. So for instance, if you have breast cancer or lung cancer, a fair number of those patients will go on to develop metastases in their brain. And that is in some ways a different entity from a pathological standpoint than the kind of tumors that arise within the brain and tend to be, in the majority of cases, what we call astrocytic in origin, or originating from astrocytes, which are the supportive structure of many of the cells in the brain. There are benign varieties of brain cancer, such as, for instance, meningiomas, which arise from the meninges, or the outer layer of the brain, and they're a different subset within the pathology of brain tumors. I think in the majority of cases, people present with headaches. And these are headaches that are different than what you would ordinarily experience. All of us get headaches. But once these headaches start becoming frequent, when they don't go away, when you take Tylenol or Motrin and they're still there a few days later, it starts becoming alarming. So headaches in nature that are basically different from the baseline headaches that become persistent, unresponsive to medications, are usually worrisome. Some patients develop seizures, so they will have a new onset of a seizure, they will collapse at work or something will happen. And that can certainly be a manifestation of a tumor. In other patients, it's more gradual. They start losing function. For instance, they become progressively weak on one side of the body. Or they start developing different problems, for instance, with their vision, with their sense of smell, or any type of bodily function that you can imagine is responsible, basically, from the central nervous system. It depends on the severity. If it's acute, some people just go to the emergency room because if you have a seizure, it's scary. So most patients will wind up calling 911 and they'll be taken to a local emergency room where they'll undergo a workup that will include some imaging of their brain. In other cases, patients certainly present first to their family care doctors or to their internists, and they will present with some of these symptoms that are relentless and don't go away. And as a result of this, they'll undergo further workup, which ultimately may lead to the diagnosis of a brain tumor. So imaging is a critical component of, I would say, neurological disorders, and neurosurgery in particular. And it's an ever-evolving field. Some of the basic technologies have existed for quite some time, for instance, CAT scans of the brain, MRIs. But what the field has recently done over the last, I would say 10 to 15 years, and really focus on advanced imaging modalities of MRI, including, for instance, something like MR spectroscopy or cerebral blood volume measurements, where we can actually pinpoint the area of abnormality, look at certain differences between that area and the brain, look at the blood flow within that area of abnormality, and based on some predictive studies and factors that are associated with it, have an idea of what we're dealing with, and whether it's a tumor or maybe a demyelinating plaque like you would see in multiple sclerosis, or maybe even an infectious problem. I think the most interesting thing about neuro-oncology is that it exists as a field, and as a field it encompasses really very diverse group of physicians that involve neurosurgeons, neuro-oncologists, which are sometimes trained in neurology, sometimes in oncology, radiation oncologists, neuropathologists, neuroanesthesiologists, and so on and so forth. I think in the majority of cases, patients either present to the neurosurgeon and or the neurologist or oncologist with a diagnosis of a brain cancer and then get basically referred to other specialties. But it's a very multidisciplinary field that involves really quite a lot of the medical specialties in order to take care of the patients.